meaningful use, interoperability, and the effect of the COVID-19 pandemic. In an effort to bring the U.S. healthcare system into the digital age, Congress passed several acts and implemented financial incentives. Meaningful use set objectives for organizations to meet in order to receive these monies. By 2015, 96% of non-federal acute care hospitals had a basic EHR, but the surge in EHRs had unintended consequences. It saturated the market, and multiple companies were unwilling to allow external applications to connect to their software. Because of this, sharing of health data has lagged. The COVID-19 pandemic shocked the healthcare system and thrust it into the use of telemedicine. In January 2020, less than a quarter of U.S. healthcare systems had a telehealth program in place. But 2 months later, use of virtual care in metro areas like New York City grew by over 4,000%, and in-person visits declined by 80%. People signed up for portals and substituted appointments with e-messaging. There is no doubt that telehealth services have saved lives, but between MU incentives and the pandemic, EHR implementation outpaced building the infrastructure necessary for inter-program communication. With an increase in mHealth, patients have faced concerns about depersonalization, quality of care, and security. They've had to adjust expectations about communicating with their physicians. Research shows that compared to pre-pandemic baseline, physicians spend more time than ever within the EHR, estimating only 1 hour with patients for every 2 hours spent in the record, reviewing test results, histories, and managing e-messages. E-messaging alone is up 157%, and there's evidence that this is a specific predictor of physician burnout. To provide telehealth services, COVID forced rapid changes to regulatory measures and reimbursement services. But demands in the EHR are not in line with existing fee-for-service payment systems. As payers reimagine what new models will look like, they should also take care to not intensify EHR-driven burnout. Telemedicine put additional access burdens on populations like the elderly, impaired, and disadvantaged. While many are now more comfortable using telemedicine, others remain concerned about their consent to the process and quality of care. This model must be continuously re-examined as it can create more vulnerabilities for certain populations. Lack of interoperability has led to the inability to share information, and quality care depends on having the necessary data. Our telehealth system, provider, patient needs, and reimbursement structure must be evaluated so that professionals and policymakers have evidence on which to build and fund essential services. Informaticists are poised to evaluate, design, and execute structures to meet the needs of data sharing to improve safety and quality of care.
Created using Powtoon.